Ready to go when you are, Dr. Krychman.
Great. Well, thank you, everybody. Welcome to our WebEx. I'd like to thank everybody from Berkeley Life for making this possible. Tonight, we're going to be talking about sexuality for the aging woman, issues and answers. I would like to just give a little brief introduction. I'm Dr. Michael Krychman. I'm a board-certified OBGYN. I'm also an ASEX certified sexual counselor and sex therapist. I also bring, a different perspective to sexual health, marrying both the medical and psychological aspects of sexual health. Currently, I am the director of the Southern California Center for Sexual Health and Survivorship Medicine. I'm also seeing patients clinically in Ann's Clinic, which is a high-risk breast ovarian center. I am very excited to be a part of this WebEx, which I hope will develop into a series about female sexual health and the importance of nitric oxide. And we do have a guest speaker who I'm very excited to share the screen with. Beth Shirley is here. Beth, you want to give yourself a shout out and give everybody a little bit of your intro, if you don't mind?
Sure. Hi, everybody. Beth Shirley here. I'm a pharmacist and a certified clinical nutritionist. So I became a pharmacist thinking that I was going to help people. And after 20 years of seeing people come back sicker and sicker on more and more drugs, in 1997, I became a certified clinical nutritionist. So I became the pharmacist to go to if you wanted to get off drugs or not go down that road to begin with. I also started monthly women's health seminars, teaching women how to live more within, teaching them to be the best self that they can be. And so I've been in the nitric oxide field since 2009, and nitric oxide plays a humongous part in response and orgasm and anxiety and depression. So we're going to talk about all that tonight. Thanks.
Great. Thank you for that. And, I am, one of the experts in sexual medicine, certainly getting caught up to speed about the importance of nitric oxide, and really in my infancy of learning how important and vital it is, not only to sexual health, but to overall general health and wellness. So we'll try and interrelate all of these facets together as we chat today about sexual health and aging. So some important fast facts. I think, the reality is that, we are now in an age where postmenopausal women are living stronger. Their numbers are expected to rise, by 2023 to 1.1 billion. And about 5,000 women enter the menopause every day in the United States. So this population certainly very, very important in the overall management of women's health care. Very important to recognize that a woman will spend, up to 30 to 40% of her life cycle in the menopausal years. So the menopausal transition also, a chaotic time, not only for hormones, but also nitric oxide. Certainly also very important, not only in sexual health, but overall general health as well. About 50% of women will suffer from vaginal dryness, painful intercourse, and very few are treated. And those that are treated, the compliance and adherence is quite low. So we do see a decline associated with the lowered estrogen stores, as well as the emergence of sexual complaints, not limited to dryness, arousal, orgasm, dysfunction. And as what was alluded to, these are very important factors, not only for the interrelationship of hormones and anatomy, but also how nitric oxide is certainly very important. The vast majority of women certainly are suffering in silence. And what that means is that, a woman is actually very appreciative if their healthcare provider will address those concerns. And the clinician really it's a conspiracy of silence. The clinician says, well, if these concerns were important, then, the patient in front of me would bring them up. And then the patient themselves, they say, well, if sexual health and intimacy was important for my overall general health and wellness, I think that the clinician would bring it up. So both are kind of on this fence, playing this dance of discussion where the other thinks that somebody should bring it up. But we do know that when a healthcare professional does bring up these questions, it certainly results in an important and very dynamic therapeutic relationship. And we'll give you some clinical pearls that you can really implement tomorrow morning, if you'd like, into your clinical practice of how to broach these topics as well. So very important to kind of backtrack and say, well, what is sexual health? So it's not only about the biological or physical aspects, it also encompasses emotional, mental, and social well-being related to sexuality. And it's not merely the absence of disease, but, good functioning, positive respect, approach to sexuality, pleasurable and safe sexual experiences throughout the course of the life cycle, no matter where you are, whether you have chronic disease, whether you are taking medications, certainly sexual health and general health remain very much intertwined. And this has kind of been my mantra for the past 3 decades while I've been in the sexual health field, is that there has to be really an evolutionary advantage. After you have finished your reproductive capacity, there has to be a reason why sexual health is very important for the human experience. And you can see here, there's a whole variety of things. We're going to dive into the whole oxytocin concept and endorphins. We know that the literature supports decreased stress by good sexual function, overall happiness, improved cardiovascular health. It's good exercise, it improves sleep. And this certainly is related to oxytocin release, pelvic floor issues. There is some emerging data to support a good sex life may even help with disease. It may have decreased issues related to prostate cancer and or breast cancer as well. And not only sexual self-esteem, but also immunity as well. So I'd like people to start thinking that sexual health is general health is sexual health. And it's just not this esoteric concept about emotional connectivity. There has to be a utility. And a lot of these are related to hormonal shifts, related to positive benefits in disease and outcome as well. And we know that it's important as people age. We've looked here, and if you look at this survey, and even though it is over a decade old, the same holds true with newer surveys as well, that even as you age, sexuality is really a critical part of the overall quality of life, overall experience for both men and women. And we see that if you have chronic disease or you have trouble with maintaining or attaining sexual responsivity, that may be impactful not only to your sexuality in general and sexual functioning, but overall to your entire quality of life issue as well. And this was, just reinforcing this a few years later, we saw that even for both men and women, it is extremely important, moderately to very, or even extremely important in terms of your overall life quality. So again, there are far-reaching benefits to maintain an intimate relationship with your partner. And one of my passions really has been looking at couples who, as they stay together and as the duration of their relationship increases, so does their sexual frequency. Very often we're told that as you are in a relationship, the longer you are in a relationship, the less sex you have. But one of my interests is, how do you maintain that sexual intimacy, that improved quality of life, all the natural benefits that you have by maintaining sexual frequency as you age and as you might be facing chronic disease? So those are really important tenets to remember. How frequently have you had sex in the past 12 months? And we can see here that even though sex is important, we aren't always doing very well. We don't always prioritize this, and it's not always on our top of the things to do list. And very often, I would say life gets in the way, stress and fatigue, privacy issues, chronic medical conditions, medications certainly are impactful. And also the natural process of aging may help hinder a good active sex life. Again, remember, men are more number counters, so they're looking at frequency. Women tend to not only look at frequency, but also look at quality. So again, very important to recognize that sex typically once a week is the natural mean across all age groups for all people, and this tends to decline with age as well. What about the prevalence of sexual dysfunction? And you can see that really, as we said earlier, this is really a conspiracy of silence, and up to 43% of all women will experience a sexual problem. And I always say, you know, look to your right, look to your left. One of you is having a sexual complaint, and remember that these are the natural fluctuations that can occur during the natural course of aging, with disease, with life, and what have you. But when it becomes distressing, when it's really impactful, when it's really distressing to yourself or your partner, that's when we really need to seek therapeutic intervention. And we can see about 10% of those sexual complaints relate to sexual desire or hypoactive sexual desire disorder. And again, not too far off, arousal and orgasm, and again, rounding it off at about 12%, any sexual complaint. The other thing I think important to remember is that very often there's concentric overlapping circles. So if you have one problem, look for another. And these are the definitions. And again, these are billable, codable events. You can see here the ICD-10 codes, female orgasmic disorder, and really we're looking for about 75% of the time. And it's really about the issues related to intensity or latency. Time to orgasm has increased and the intensity has diminished. And that might be, in fact, due to some of the underlying issues that women are experiencing, whether it's hormonal shifts, whether it's changes in nitric oxide. And we'll jump and talk about some of those implications as well as Beth talks about arousal and orgasmic potential. Female sexual interest and arousal disorder, again, remember that in the past they used to be separated. Now they are really one combined issue, and it's really related to this ability to have sexual thoughts, arousals, and initiating activity. And again, we have the temporal association in almost all 75% or 100% of encounters. Genital pelvic pain penetration disorder previously was vaginismus and dyspareunia. They kind of lumped these all together, really associated with pain with penetration. There is undoubtedly an anxiety component as well to this condition. And again, looking for underlying abnormalities, certainly very important when you're looking at anatomical issues. I think it's important to recognize that when you're classifying, you need to be able to go to lifelong or acquired. And again, lifelong always had an issue, acquired where there was a period of normal functioning. So there was really an insult, and that's from that time forward, you've had a problem. Generalized, all situations. Situational, only one situation. So generalized, like even if you're on a vacation trip to Hawaii and you're not having sex, that is a generalized. But if you go and you say, when I go away and the kids are at home and I don't have the stress of work, that's a situational issue. And again, the context and the onset are very important to understand and define, and also are impactful in terms of therapeutic intervention. So what about sexual function? What are the tenets? What are the important facets in terms of overall sexual functioning? We know most of the activity is above the neck in the brain. We know neurotransmitters, as are listed here, dopamine, serotonin, epinephrine, norepinephrine, certainly vital and very important. We have different areas of the brain, and we've done fMRI studies as well, looking at women in the MRI machine when they're undergoing arousal, and different areas are highlighted. We know through staining where and which things are concentrated as well. And don't forget the hormones as well: estrogen, testosterone, oxytocin, opioids, and pheromones. And we'll put that into context as well. And again, this is really to kind of let everybody know it's always a push-pull. There is always excitation and inhibition, and it's really the balance of that really allows you to have desire or arousal. So you have here listed dopamine, norepinephrine, testosterone, estrogen are excitatory for desire, but then you have inhibitory issues of serotonin and prolactin. So it's this push-pull. What is winning? I'm more excited than inhibited, so then my desire is a more positive aspect. But if I'm being more inhibited and there's not enough excitation, then I won't have desire. And the same thing holds true with arousal. And you can see here dopamine, norepinephrine, testosterone, estrogen, and nitric oxide, acetylcholine, also very important. And inhibitory, we have prolactin and serotonin. So again, this push-pull, the positives, negatives, and it really depends which is predominant. Now I'm gonna let Beth jump in and talk a little bit about nitric oxide and let her kind of steal the show and get a discussion about where this is quite impactful. Beth?
Hi. So I feel our sexual energy is our life force energy. It's a source of all our creative energy. And the female genital response is all mediated by the nitric oxide, and it all starts in the brain. The hypothalamus needs nitric oxide in order to make LHRH, luteinizing hormone releasing hormone, which then goes to the pituitary for the release of LH and FSH, which then go down to the ovaries and testes to make your estrogen, progesterone, and testosterone. And in turn, these hormones stimulate endothelial nos to make your nitric oxide. And as you see on here, there's only two main hormones here that interfere with the production of nitric oxide. And that's your glucocorticoids, your cortisol, your stress hormone, and your prolactin. Just like he was saying, the prolactin is inhibitory. So this NOS enzyme, though, so this is a good circle, good cycle. But this NOS enzyme can become uncoupled or dysfunctional for many environmental factors: age, diet, lack of good nitrate veggies, lack of nutrition, lack of exercise impairs the NOS enzyme, medications, antibiotics, antifungals, antidepressants, the SSRIs antidepressants interfere with the production of nitric oxide. Birth control pills, NSAIDs, your ibuprofen, your PPIs interfere with the production of nitric oxide. EMF, and we're swimming in the sea of EMF, pollution, glyphosate, genetics, your genetic SNPs, and the big one, stress, causes nitric oxide to be inhibited. So this is a good cycle. We need nitric oxide to get things started. And then these hormones help make the nitric oxide. Next slide. So nitric oxide acts like a neurotransmitter in the brain, modulating the release of oxytocin and your LHRH. And both of these are central in the modulation of sexual behavior. Our oxytocin, our cuddle hormone, our love hormone, increases nitric oxide production through that NOS enzyme. And in turn, orgasms increase oxytocin. Nitrates increase the production of a nutrient essential cofactor called BH4, tetrahydrobiopterin, which not only helps make that NOS enzyme work, it increases your production of your neurotransmitters, including dopamine. And dopamine is our major player in the reward pathway and stimulates sexual desire.
Great. You know, I think that's really interesting how nitric oxide has such an important and vital role centrally in terms of starting and maintaining that cascade of events that are going to lead towards, you know, improved sexual function in every aspect. And this slide really is, how does that translate from a central acting to a peripheral tissue response? And you can see here, you know, the direct effects of nitric oxide on vasocongestion, the positive effects of 5-HT2A, norepinephrine, prostaglandins, as well as fibers that are all about vasocongestion. They will affect the clitoral and penile tissue, improve sensation. So again, I think it's important to recognize that the role is not just a centrally acting phenomena, but it has far-reaching effects even in the periphery, right, Beth?
Exactly. So sexual arousal encompasses a variety of physiological responses, all mediated by nitric oxide. So nitric oxide is a potent vasodilator of the clitoral, labial, and vaginal tissue. It acts like a non-adrenergic, non-cholinergic neurotransmitter in the clitoral corpus cavernosum to relax those smooth muscles, just like it does in males, to increase the blood flow in response. And increased blood flow means better orgasms. Nitric oxide also decreases anxiety, which increases sexual pleasure. It's involved in creation of long-term memory, and many studies show that memory and libido are closely connected. It enhances the ability to remember the sex sense, the pheromones. Like even if you can't consciously smell them, you can unconsciously. And nitric oxide mediates lubrication. So nitric oxide has everything to do with being able to respond and everything to do with lubrication. And as women, if we can't respond and we're not lubricating, do you think we even think about sex much? Probably not.
Right. And, I think that's really critical about the concept of memory and libido and sense. And again, shows really the integration and the far-reaching effects of nitric oxide on the sexual response cycle and the perception of sexual response. Again, many of us, have a lot of memories or sense that are triggered. I don't think many people know, I do have a degree in aromatherapy, so I have a very intricate understanding about, pheromones and their ability to enhance sexual function. So I think this is a really critical point, that we know that it works both centrally and peripherally as well. And again, this is really just an overall arching diagram where we can see how desire, excitement, and arousal, orgasm are interrelated. We talked a little bit about the oxytocin pathway. And again, you can see it's a really dynamic, intricate interrelationship of how they are really overlapping in concentric circles in terms of the hormones, the neurotransmitters as well. And this is what we had talked about before. I think when you're talking about sexual health complaints, very often you have to be what I would call a sexual medicine detective. Very often women will come in with one complaint and they'll leave with multiple diagnoses. In my center, it's not uncommon for an individual to present with vaginal dryness, and then subsequently, after asking a few questions, she has dryness, she has pain, she has lowered interest, she's not getting aroused, there's no lubrication, and sex is painful. And then orgasm is also not on the table because she's not aroused or lubricated or what have you, and then she develops this pain syndrome. So again, when you have one problem, I think it's really important to think that there may be other problems in tandem with this issue. And this, we talked about it before. We talked about the biopsychosocial model. And again, remember biology, veins, arteries, nerves, hormones, neuroendocrine issues, sociocultural issues really relate to the culture, your upbringing. What are the hidden messages you got about sex, about orgasm? Is orgasm really about complete loss of control? Is sex used as a weapon or what have you? We talk about anxiety and depression, and I think that's really important as well. And as we become more sleep deprived in our working paradigm in the 21st century, we work more, we sleep less, there's more anxiety and depression, and it's not without understanding why our sex lives aren't so great. So anxiety, depression, underlying other psychological problems may be problematic. And we shouldn't also negate the importance of understanding the context and really about interpersonal, the past relationships, life stressors, financial concerns, and what have you. All certainly very, very critical in the overall treatment paradigm of understanding. So again, I think the important concept is to remember is that there's not just one etiological path. Very often there's multiple etiological paths that lead to the same issue or condition. I think here when we're looking at aging, really there is a change in hormones. We see a decline in estrogen, androgens, and this may occur, 7 to 10 years before the final menstrual cycle. You'll see changes in orgasm. My menopausal patients will say orgasm used to be thunder and lightning, and now it's pitter patter of rain. And I'm waiting and waiting and waiting with my umbrella for something to happen, and nothing happens, and I get frustrated. So the issue of dyspareunia, vaginal and vulvar atrophy, this preconceived issues, changes in health status, more medications. The average elderly person will take up to 4 chronic medications, all which may be impactful on the sexual response in one way or another, whether they're affecting direct or indirect. The underlying anatomical and physiological issues. There's also a decline in sexual activity, as we mentioned as well. So, Beth, what about nitric oxide and aging? What's your thought?
Well, by the time we're 40, our ability to make nitric oxide decreases to about 50%. And by the time we're 60, we're only at about 15%. Remember all those things that I said nitric oxide is needed for, and to be able to respond, for lubrication, for anxiety. And us women can hold on to that ability a little better than men because of those hormones, because of the estrogen. But then once we reach menopause, it's kind of at the same level as men.
Right. Yeah, I mean, I think this is remarkable that even earlier than, the perimenopause, you're seeing a gradual decline. And I think that points to the fact that even as you look at 30-year-olds and 40-year-olds, the issues related to sexual problems is not uncommon. We see many individuals in their 30s and late 30s, 40s that are complaining of sexual complaints. And this certainly can be a contributing factor in terms of the overall decline in nitric oxide. I think very important and critical to remember that as you're assessing your patients. So very important as we go through the menopausal transition, there is a loss of estrogen and androgen over time. You have an acute change. Perimenopausal window maybe up to 7 to 10 years before the last final menstrual period. 51.3 is on average, and you can see hot flashes. They can last for 5 years, some unfortunate 7 to 10. And then you have the super flashers, which can last up to 20 years. And you will see that some of them are long-term symptoms, which are changes in arousal and libido and decreased sexual activity with associated DSM type situation, and some are actually perceived as short-term symptoms. But again, as we mentioned, some women do suffer from long-term hot flashes as well. What about the other issues that are certainly relevant as people are aging? I think there's issues with changes in mobility and physical limitations. Again, this concept of we are a chronically fatigued nation, and I know Beth will talk about the changes in sleep pattern and changes in cortisol. We are a pill popping, consuming nation, and this gets more and more prevalent as we get older. The average menopausal or aging individual can take up to 4 chronic medications, all that can be impactful. And believe it or not, there's over 300 medications that can impact vaginal health, impact the epithelium, impact and cause vaginal dryness and dyspareunia. We're gaining weight, metabolism changes. It's much harder to have, very positive sexual self-esteem as well. And there are certainly changes in the relationship. What happens at midlife? Sometimes children are leaving the home. Sometimes they're returning from college. There is an imbalance. Sometimes you're retiring. Sometimes you're not. Sometimes there's financial concerns. Sometimes there's not. So there are also these dynamic of relationship concerns that do go on as the couple ages together.
So we all need to feel like we're in the mood, and that plays a part in everything. So nitric oxide is involved in the regulation of anxiety. In anxiety and depression, we see low levels of BDNF, brain-derived neurotrophic factor. And nitric oxide mediates those neuroprotective actions of BDNF, promotes neuronal survival, stimulates the neurogenesis, enhancing learning and memory, plays a role in synaptic plasticity, which positively affects mood. Nitric oxide increases GABA in the brain, our inhibitory neurotransmitter, which decreases anxiety. And SSRIs are notorious for inhibiting the production of nitric oxide. They decrease nitric oxide production and they block arousal in both men and women. And SSRIs can lead to problems with desire, arousal, orgasm, and even ejaculation in men.
Right. And I think this is really critical to kind of understand that, you know, nitric oxide is certainly very important in mood and mood regulation and anxiety, whether it is caused by changes in nitric oxide or in and of itself. I think this gets to a, you know, a vicious circular pattern, right? The more anxious you are, the more you become anxiety, you have depression, you're not functioning well. It will impact your production of nitric oxide, and that just doesn't bode well, and it enhances the underlying pathology that's going on. So again, very interesting also the integration between central and peripheral as well. And when you're anxious, you're not sleeping, and those certainly have impact on your cortisol, which also is quite impactful.
So stress initiates that fight, flight, freeze response. And this makes all these non-essential functions like sex drive just go away. So when you're running from a tiger, you're not thinking about getting it on later on. So stress from any source, whether it's physical, emotional, psychological, mental, any kind of stress increases cortisol, the stress hormone in the body. And when the adrenals produce more cortisol, when there's a deficiency of nitric oxide, the adrenals produce even more cortisol. So this is a bad, vicious cycle. And cortisol is one of the only hormones that increases with age, and one of the only hormones that negatively affects nitric oxide levels. But the beautiful thing about regular sexual activity, it decreases this sexual response, the stress response. So sufficient sleep is essential for healthy sexual desire and genital response. Studies show that the longer sleep duration was related to greater next day sexual desire. REM sleep is nitric oxide mediated. When you have impaired nitric oxide production, you see a phase shift in the circadian clock and disturbed sleep. So this is one of those vicious cycles.
Right. And I think that's really critical about sleep and the importance of sleep and the power of sleep. And we know that menopausal women, not only are they suffering from the issues related to depletion of nitric oxide, but they also have vasomotor symptoms of hot flashes. So in and of itself, it's kind of a compounded issue, right? So they have lowered estrogen, they're hot flashing, they have chaotic, interrupted sleep. And this is really associated with a lot of downstream issues: daytime fatigue, loss of libido, mood changes, anxiety. So again, it's the kind of the interplay as well. So we know that with libido, with aging, we do know that there is a change. And we do know that there's distressing symptoms and they peak during midlife, lowest from age 65 onward. And that's not because of the incidence, it's really because of the distress, right? And there's decreased estrogen. We talked about the changes in the vaginal epithelium, and changes in the androgens also decline and are correlative with changes in desire, arousal, and vaginal lubrication. Beth?
So sexual desire is cultivated in the brain. Our sex organs rely on hormones and neurotransmitters to promote our libido, as well as to support changes in our blood flow that are needed for the sexual acts. So nitric oxide is the essential component of female sexual health and satisfaction. It's required for response. It's required for lubrication, required for orgasm. So nitric oxide production naturally decreases with age, reducing to about 50% by the time we're 40 and only about 15% by the time we're 60. So by supporting the nitrate to nitrite to nitric oxide pathway, we can support that nitric oxide production. And optimal nitric oxide is the essential component in both male and female sexual response and satisfaction. So we'll talk about the nitrate to nitrite to nitric oxide pathway in a little while.
Right. And we know in the perimenopause of the time leading up to it, we still have changes, as we talked about, changes in desire, pain increases, and it's kind of irregular. Frequency also remains relatively constant, despite the challenges. So it's kind of this organized chaos, one foot in the cycling world, one foot in the non-cycling world. And again, that associated with the decline of nitric oxide as well. So many women will report disappointment, no longer have desire, and there's a loss of sensation as well. So they have decreased desire, but also decreased responsivity, decreased pleasure. And we talked about the sexual self-esteem. There may be associated with depression, dissatisfaction at home, changes in emotional and physical relationships, and even relationships are certainly impacted as well. I do think these are really important icebreakers. And remember, we talked earlier on about how do you broach these topics? And I think, I always say you have 2 ears and 1 mouth. As a clinician, we tend to speak more than we listen, and it needs to be the reverse. You need to listen more and be silent much more. You need to be engaging in your patients. These are some icebreakers. Are you presently sexually active? We want open-ended questions, effective use of silence, and really normalizing statements. Many women have sexual concerns at this time of your life. How about you? Do you have any concerns that you would like to discuss? Have you noticed any changes in your sexual interest? So again, I think open-ended questions that allow the patient the opportunity to speak freely will lead you to those important questions. And then you can kind of drill down and then talk about desire or lubrication or sexual dissatisfaction. And again, I think it's important to remember that if an individual says, I'm okay right now, I don't have any issues, I think it's important to normalize that and say, I understand and I recognize that, but also remind them that this is a safe place. And I always say, I recognize that you don't have any sexual health concerns, but this is a safe place. And I'm going to ask you again when I see you again, and maybe things will change. And I want you to know that if you go home and change your mind, or if you have second thoughts, this is always a safe place where you and I can talk about these issues and we can address your concerns in a systematic way. And there's no need to suffer in silence. There's no need to be engaged in this conspiracy of silence. It's very important to have your issues and issues addressed and have your sexual health concerns really treated in a safe, effective way. So with that, I wanted to just kind of sum up and kind of say, sexual functioning, we talked about a lot of these facets, medical history, culture, partner relationships, stressors, sexual self-esteem, and let's not forget hormones and neurotransmitters. So like a sun, there are so many different facets that can influence or get short-circuited in the facet of sexual functioning. And as we develop a treatment paradigm, so too should it be multi-layered, and so too there are multiple ways to effectively treat sexual dysfunction. Many simple suggestions: using a lubricant, using a sexual device or sexual stimulator, sometimes sexual pharmacology, sometimes supplements may be very helpful in order to improve and enhance the sexual responsivity. Treating systemic illnesses, medications, pain management, counseling. And again, think of it as a multi-dynamic phenomenon with multiple entry points for treatment. And again, remember that referral is never a failure. And you also have to know your limits. So arrogance and ignorance, bad combination. If you feel that this would be better served, there are sexual medicine experts, there are counseling experts, and you can always say, look, we've gotten the limit where we can in this area, but I would like you to see a specialist. And here are some referrals. So building a referral network is also very, very important. And the goal is not to make everybody sexual medicine experts, but really feeling comfortable about addressing these issues on a day-to-day basis. And it takes a comprehensive team. It's not just the OBGYN or the urologist or the sexual medicine expert. Sometimes you need nutritionists, you need exercise physiologists, physical therapists, you need nutritionists and what have you. So again, it's a building of a team. Sometimes you need to work with the professionals that are addressing the chronic medical conditions as well. So you're not alone. There's a support system for healthcare professionals as well, and you should access them as needed and build your healthcare, sexual healthcare team accordingly. There's always a good opportunity for education. So again, education is key. There's a lot of myths and mythology surrounding orgasm, surrounding sexuality, surrounding sexual positioning, sexual devices. So it's always a good opportunity to provide education for your patients, and you have a captive audience. So I think very important to discuss anatomy, discuss responsivity, and kind of dispel some of the myths. And there's a lot of very good resources that are available online or books and what have you. And certainly we can make those available. So just to sum it all up, aging is certainly a natural progressive process, normative and expected sexual and sexuality changes through the life cycle. We anticipate these. We know that there's going to be changes in hormones. There's going to be changes in nitric oxide, but safe, effective interventions, simple interventions could have huge impact on overall functioning. Sexual dysfunction can affect the individual, it affects the partner, it affects the couple. So in essence, there's multiple patients that you're treating. Chronic medical conditions, what we do iatrogenically, what we do in terms of medication to keep disease at bay, whether it's medication, surgery, chemotherapy, radiation, they have a major role in sexual health status, and they very often can lead to sexual dysfunction. We know the neurohormonal connections are really important, and they facilitate desire and arousal response. Nitric oxide is certainly one of many important components in the overall sexual health paradigm. And just like sexuality has multifaceted entry levels, multifaceted approach to arousal and desire and orgasm and stimulation in multiple areas that are impactful, so should the therapeutic options. So again, we know that it's multi-dynamic, there's multiple etiological factors, veins, arteries, nerves, hormones, neurotransmitters, and this interplay with the psyche and what have you, and emotion and mood. So too should your therapeutic interventions really cross the board. And there are safe and effective treatments that can have huge impact on overall sexuality, sexual enjoyment, pleasure, satisfaction, and subsequently improve overall quality of life. So with that, we will conclude. We'll open up the floor to Q&A. I know we went a little bit over, but we still do have some time for some questions and answers. And I think, John, are you going to facilitate that?
Absolutely, yeah. I've been curating the questions here as they've come through, and have a nice list here for us to run through in the 15 minutes that we've left, both for yourself and Beth. So just to start with, and it's honestly, it's a question for me because I get it quite a lot, is when you're dealing with the patient, discussing female sexual function specifically, is there ever a scenario where you choose to engage the couple versus just the individual patient? Is there any value in that or any benefit in that?
Well, I would say that it's always very important to see the dynamic of the couple. And when someone calls for an appointment for a sexual medicine evaluation, I really leave it up to the individual, and I always allow partners to come. You get a lot of information about the dynamic and about the relationship issue. I recently saw a couple, to give you an example, and it was a heterosexual couple, cis man, cis woman. She comes in looking at the floor, and her complaint was no orgasm. And he walks in and he says, you've got to fix her. I've been with thousands of women and been able to give them orgasms. What's wrong with her? So, sometimes the interaction gives you an understanding of their communication skills. It gives you an understanding of the stress of the relationship, Not all relationships are positive. Sometimes there's a lot of emotional abuse or what have you. So I always advocate that. And remember, I always say, very often sex is a partnered activity. So, and only if the partner wants, the person you're treating, they can be invited into the situation. But you do glean a lot of information about that psychological issue, the trauma, potential communication issues, and what have you. So I would encourage that, maybe not on the first visit, but certainly thereafter.
Okay. And some more technical questions, I guess, is, how can you help boost libido in women whose hormones are already balanced?
So again, I think for me, I use a layered approach for lowered libido. So my approach is, I would say, from conservative to aggressive. So certainly hormones are very, very important. But as we know, even replacement of testosterone has a very high placebo effect. So I use a conservative to more aggressive approach. You want to do what I would call conservative behavioral interventions and understand, how is libido important? Is sex important? What are they doing? What are their interactions as a couple? What's their physical intimacy in terms of spending time together? Then you go into emotional support. Are they communicative or operational? Are they only talking about the kids or soccer or the mortgage or bills? Or are they talking about their relationship and how much emotional sharing and caring? Then we go to sensual intimacy. What is the foreplay? What is outer course? Are they engaging in manual stimulation, oral sex, and what have you? Really, I think that even hormones are optimized. There's other FDA-approved medications. So again, I think it's a layered approach. So it's not uncommon for myself to have people on supplements, not only nitric oxide, but other enhancers as well. And then they're on hormonal therapy. And then we can even add others, which are more centrally acting, like Adi or flibanserin is FDA approved. It's a 5-HT1 agonist, 5-HT2 antagonist. It works as a serotonin modulator. There are other things like Vyleesi that is approved for desire and arousal issues. There are things off-label, right? Like Wellbutrin, which is also a prescription. So again, I think it's a multifaceted approach, and you really have to say that there's not one size fits all. If you have 100 women that have normal hormones, whether you get them on the street or you're repleting them and they're normal, 1/3 will have great desire, 1/3 will have low desire, and 1/3 will have normal desire. So there's no real correlative to especially testosterone levels and sexual function. And I also think that we underestimate the importance of estrogen and estradiol. That I think is very, very important as well. And remember, the thing with hormones is when you are sexually well, when you are 21 and you're doing amazing, we typically do not measure your hormones, right? And then when you come in your 40s and your hormones are lower, when we replace you to the level of normal. We don't know what's normal for this particular person in front of us. They may be high normal. They may have lived at above normal for their age. So hormones are very challenging. So I think we need to kind of take a step back and not only think about the biopsychosocial model, but not only hormones, but the context in which desire is happening is also very important.
And just while we touch on estrogen, it kind of crossed over into some questions we have in NO. Question is, can we replace vaginal estrogen with NO for lubrication?
Beth, do you want to take that one?
It's a good place to start, but estrogen is required too for the healthy vaginal tissue.
Got it. So it's kind of a mixture, kind of.
Yeah.
Yeah. Okay. And on a similar note then, Beth, do you change the dosing at all for menopausal women depending on symptoms or age? Dosing of nitric oxide, that is.
Not necessarily. However, you can do your regular dose. Can we talk about the Berkeley?
Yeah, absolutely.
So Berkeley is a nitrate-based product. So it supports the nitrate to nitrite to nitric oxide pathway, which is different than the arginine NOS pathway. So this pathway is not impaired with age. And so the usual dose is 2 capsules in the morning. And then a lot of times I'll have people take, like if they're having sex in the evening, have 2 capsules an hour prior to activity. So, but Berkeley makes test strips so that you can test your saliva to make sure that your levels are healthy. So you can always use that. If you're adding like high nitrate veggies at lunch and dinner, you might not need that extra dose in the evening.
And just given the topic, do you see, or would you be cautious of any contraindications for using it for fertility or for pregnancy?
No, in fact, nitric oxide is critical for every stage of fertility, from the sperm formation to how the sperm swims, to the egg formation, to the implantation. Nitric oxide is critical in every stage of fertility and pregnancy.
Okay. And just for you, Dr. Krychman, that in terms of regenerative treatments, do you recommend or use things like PRP or P shots or O shots, etc., in your practice, or do you have people you refer to that use those types of treatments?
Well, what I would say is I'm very much data driven, and while I think these procedures are new and innovative, I still think that the data is in its infancy. And you also have to remember that I'm a tertiary referral. So I'm always seeing the worst of the worst or the complications or what have you. So I do believe in innovation in sexual medicine, but I also believe that we need to gather data in a systematic way. And again, I think PRP for men certainly more advanced in terms of literature, in terms of outcome-based issues, in terms of the treatment of ED, not so much for women for the O shot. And again, I think that is certainly very challenging. And I think some, and I'm not saying all, I'm saying some are not appropriately trained. They've overpromised, they underdeliver, patients get very frustrated. And again, I think you need to do a comprehensive, thorough evaluation. Remember, orgasmic issues, there's a high level of medication-induced issues related to it, lubrication, arousal issues, blood flow issues, and not to underestimate the factor of spectatoring or distraction and what have you. So I certainly have seen people that have had these procedures both on the male and female side, but again, I am not performing them, and I have a different perspective based on my clinical acumen.
Great. And I suppose outside of the potential for nitric oxide and female libido, what other supplements do you recommend? Maybe not for libido specifically, but for the patients that you see for this type of issue?
So for a variety of different ones, I mean, there are some that do I try to find some like Berkeley Life in terms of nitric oxide, but I do have Ristella. Ristella is from Bonafide. That has some data, was in Europe under Lady Prelox. There are a whole variety of other ones, Vitality, which works, I believe, by fenugreek, which modulates estrogen and testosterone, and there's some data from that as well. And again, I think you just really need to follow the data specifically. So again, many of these are not working on the same mechanism as nitric oxide. They're working, some of them are very high in arginine and citrulline, and we know that may not be the best method, right? Because of the impact, as we had mentioned earlier. So again, I think you need to do really a deep dive, but fenugreek as a supplement, it is, I believe, it is from Metagenics. But I would have to double check that for 100% accuracy. But that's fenugreek, and I've used that before as well to modulate estrogen and testosterone.
Great. And talking about menopause symptoms, Beth, how do you position nitric oxide or improved blood flow to support women experiencing hot flashes?
It helps balance everything. So I have had reports of people telling me that they're not flashing as much, because the hot flashes, they're based on everything that's going on in the woman too. And if they're not balanced on the insides, things aren't going to be balanced as far as the temperature either.
Got it. And a similar question, I believe it's related to your previous dosing comment. And it's come up before, but can you have too much NO, I think is the question here from Dr. Nario.
It's pretty difficult to have too much nitric oxide through that nitrate to nitrite to nitric oxide pathway. The DASH diet, dietary approaches to stop hypertension, which is used therapeutically as medicine for high blood pressure, has between 1,200 and 1,500 milligrams of nitrate per day. And in 2 capsules of Berkeley, it's going to give you a little more than 300 milligrams. So, you'd have to be taking 2 capsules, 4 or 5 times a day to get what you get from the DASH diet.
Great. And last question for you, Dr. Krychman, and it kind of comes back to the similar one we had before, but any applications currently integrating sexual energy treatment? And apologies, I'm not familiar with these, but yoni, lingam, and yoni eggs. Hopefully those ring bells for you.
There is no hardcore scientific data about any of those interventions at the current time that I'm aware of.
Okay, fair. Great. Okay, well, we're just 2 minutes shy of 8 p.m. Eastern. So I think we did a great job. We got through, I think, almost all the questions that were submitted before and during the webinar. Big thank you to yourself, Dr. Krychman, for pulling together those slides, and for Beth, as always, for your insights on all things nitric oxide. We'll continue to do our expert webinars on a monthly basis, and any questions that anyone has for the Dr. Krychman or Beth, feel free to submit those to info@berkeleylife.com. Hopefully we'll be able to share the slides afterwards and the recording as well for anyone that registered or joined us here tonight. But with that said, I think I'll let everyone to their, let's say it's today, Tuesday evening. And again, appreciate both our presenters here this evening.
Thank you, everybody.
Thank you very much, everybody. Have a good evening.
Thanks all. Take care.